Good afternoon, everyone. My name is Layla Austin, and I'm the Executive Director of the Public Affairs Alliance of Iranian Americans, or PAAIA for short. PAAIA is a nonprofit, nonpartisan organization that serves the interests of the Iranian American community. I want to welcome you all to a very special panel of Iranian American medical experts who will be helping us assess the impact of 2 years of COVID on our lives and what we can expect moving forward. 2 years ago, as the global community began to face the challenges of the COVID-19 pandemic, PAAIA launched the Iranian Americans Care campaign, an initiative to bring together our community and highlight those who were giving back during these unprecedentedly tough times. Throughout the Iranian American, medical professionals and scientists have been at the forefront of this pandemic, fighting on the front lines to save lives. As we approach the 2-year mark of COVID-19, we are honored to be hosting this most esteemed panel of Iranian American medical experts to shed light on what we can expect and the path forward. Without further ado, I will hand it over to our moderator, Dr. Sima Toussi. Dr. Toussi is a pediatric infectious diseases expert and currently Associate Director of the Anti-Infectives Research Unit at Pfizer, based in New York. She worked on early drug development of Paxlovid, Pfizer's COVID-19 oral antiviral treatment, as well as the pediatric COVID vaccine. Thank you, Sima, for helping put together this stellar panel and for agreeing to moderate.
Thank you so much, Layla, and thanks so much to PAAIA for hosting this event and bringing together an exceptional panel for tonight's event, where we'll be discussing the very important topic with the theme being from pandemic to endemic, lessons learned from COVID and what comes next. Prior to introducing our panel, I'd just like to let our audience know that there will be an opportunity to ask questions. So if you do have questions, please do put them in the Q&A and we'll do our best to address them towards the end of the program. So with that, I'd like to introduce our panel. We have Dr. Roxana Mehran, who is an internationally renowned interventional cardiologist, professor of medicine and director of the Interventional Cardiovascular Research Center at Mount Sinai Medical Center in New York. She has built a globally respected academic research center, and in addition, Dr. Mehran has been an advocate for fellow women physicians and researching cardiovascular diseases in women. Dr. Kayvon Modjarrad is the founding director of the Emerging Infectious Disease Program at the Walter Reed Army Institute of Research and also Associate Professor of Medicine at the Uniform Services University. He's a principal inventor and lead for the U.S. Army's COVID-19 vaccine and monoclonal antibodies program. He also serves as a principal advisory member of the U.S. Federal Response to COVID-19, originally known as Operation Warp Speed and now renamed to Countermeasures Acceleration Group. Prior to his current role, Dr. Modjarrad led the development of the U.S. Army Zika vaccine and the first ever vaccine trial for MERS, another coronavirus. Dr. Milad Pooran completed his medical school training and residency in internal medicine at the University of Maryland. He then completed a fellowship in allergy and immunology at the National Institute of Allergy and Infectious Diseases, followed by a fellowship in critical care medicine at the National Institute of Health. Dr. Milad Pooran is currently the head of the ICU at the University of Maryland Hospital. And our fourth panelist is Dr. Arshya Vahabzadeh, who is the Chief Medical Officer at BrainPower and also a practicing child and adult psychiatrist. During the pandemic, he's been involved in strategic development and clinical delivery of psychiatric services. He is including telepsychiatry, COVID unit consultation, outpatient care, and providing correctional mental health services. He has a strong interest in mental health policy and the development of scalable mental health technologies. So thank you, everyone. Thanks very much for taking time out of your incredibly busy schedules to be here with us tonight. So at the outset, I'd like to just, I'm just going to share a few brief slides, just highlighting a few key elements of the COVID pandemic before we start discussing with our panelists. hope you can all see. I do have to have need to share my disclaimer slide. So in December 29, 2019, over 2 years ago, a new disease emerged. There were early cases of pneumonia that were linked to Wuhan, China. A week later, this was identified as SARS-like coronavirus, and it only took another week before the first case was reported outside of China in Thailand. By March 11, the WHO declared COVID-19 to be a pandemic. And in the ensuing 3 months, by July of 2020, the first vaccine trials were underway. Since then, in the ensuing 2 years, the impact of COVID-19 worldwide has been nothing short of devastating. In those 2 years, there have been over 430 million cases and 5.9 million deaths. And recently, we've surpassed that 6 million mark. During this time, there have been over 10 billion doses of COVID vaccine administered. There are now 3 vaccines authorized or approved for use in the US. This slide just shows the 3 types of vaccines available for people and how many so far have been fully vaccinated. And by fully vaccinated, meaning either getting 2 doses of Modjarrad or Pfizer or 1 dose of the J&J vaccine. For Pfizer, there have been over 120 million people who've been fully vaccinated, 75 million are fully vaccinated with Moderna, and over 16 million with the J&J vaccine. But despite the availability of vaccine, we all witnessed a recent surge with the emergence of the Omicron variant. As you can see on the right, there is a large spike in cases, reaching 800, sometimes 1 million cases per day. Thankfully, in recent weeks, there has been a steady decline in the number of cases. So while the Omicron variant has been reportedly possibly more mild, despite that, we saw a large number of cases, and with the influx of cases, a large number of hospitalizations. Dr. Pooran, can you share with us what the recent surge experience was like, and how this might have compared with the initial surge? If it was any different for hospitals and potentially for lives?
Thank you so much, and thanks for that introduction. You know, I think the pandemic definitely came with different flavors and different different twists that always kept us guessing and on our toes. And I think that's kind of the apprehension right now as we are back in a quiet state. You know, we've been here at least twice before, only to deal with a new resurgent variant. So I think those of us who've been on the front lines, although we want to celebrate, I think, you know, we spiked the football a couple times already and hadn't quite made it into the end zone. So, you know, the last surge was particularly interesting in that although we were having better outcomes with some of our sicker patients, the reality was that it was still a fairly lethal disease. And it was so infectious, the Omicron variant, that, you know, if initially we would have 10 ICU patients, and of that 10, you know, a third would succumb to the illness. But with Omicron, it was only 1 out of 10, but we had 40 patients instead of 10 patients. And so the total number of deaths and the total mortality was actually far exceeding what we saw with the first wave, simply because of the numbers. So it was kind of a misnomer in the sense that, yes, it did seem to be less lethal, but it was certainly not less virulent and not less, you know, prone to causing significant disease. And you know, the patients who did recover still required 45 days plus of hospitalization, subacute rehab, before they could even consider going home on oxygen. So there was still significant longstanding lung damage. So that's that, you know, again, different than kind of the first iteration. We felt a little more comfortable with managing it. We felt more comfortable with the disease progression and what to expect and how to discuss the cases with the families, certainly. But I can't say that any wave was better than the other. They were all equally quite traumatic.
Thank you for that. Do you think this time around the hospitals were better prepared in terms of being able to
I think there was more uniform. Our group goes to 6 different ICUs in the DC metro area. And I think the initial wave, March, April, May of 2020, everyone was doing something different. No one knew what was right. But I think especially with our nurses and kind of their day-to-day routines and our ability to go in and out of rooms, I think we all had a much better workflow. So things did get a lot smoother across the board, I think, in the United States.
And do you think the patient experience might have been different because of that as well?
It certainly was. I think we had a lot of lonely deaths the first time around. I think we got a lot better at letting families in, especially once they were vaccinated. I think the risk benefit ratio, the ability to let vaccinated family members in, knowing the effectiveness of the PPE and the N95s, and also kind of understanding the disease progression of some of these patients, that they were no longer infectious, allowed us to bring families in a lot sooner. So even if the outcome was still bad for the families, they got to be there with their loved one, and it wasn't quite as lonely and sad of a process.
So during the first year of the pandemic, many of our patients were afraid to seek needed primary care due to manage their health conditions such as cardiovascular health, diabetes, hypertension, and there was fear of coming into the hospital setting. Dr. Mehran, can you share with us what the impact of COVID may have had on your patients and their ability to access care, especially in that first year and maybe even now?
Yeah, I mean, I think, can you hear me?
Yes.
Can everyone hear me? Oh, great. So thank you for that question, because it's incredibly important. And for us, especially in that first year here in New York City, it really was listening to Dr. Pooran, I think about how different it was for us here in New York, with that first wave being so tremendously difficult for us, and that these next 2 waves were also difficult, and a lot of it had to do with fatigue on the part of the frontline workers. But to get back to the cardiovascular care, and for everyone to remember that cardiovascular disease is the leading cause of death in men and women around the world, even with the COVID pandemic present. So if you kind of think about our patients not wanting to go to the hospitals because of the fact that they didn't want to have exposure to the COVID-19, to the virus, and to have the exposures, we had a lot of deaths at home where myocardial infarction, patients with heart attacks did not come to the emergency rooms. Heart failure patients did not come in because when they got sicker and they didn't come into the hospital. And we started to see sort of a rise of these like acute sudden cardiac death. And those were statistics that we were seeing and watching. And so much of that is, how much of it is COVID, how much of it is cardiovascular, very difficult to decipher and to adjudicate, obviously. So, and that kind of letting go of the cardiovascular care also in the general population by just staying at home, not walking, not doing, just basically becoming a sedentary life in that year in lockdown, I think also has had huge detrimental issues in terms of treatment or control of cardiovascular risk factors such as hypertension, hypercholesterolemia, and diabetes. And we saw a lot of that sort of come to fruition as the waves came down and the patients began coming in, and we started to see, oh my goodness. And as good as telehealth may be in terms of caring for patients with cardiovascular disease, there is nothing more important than seeing that patient, examining them, putting a stethoscope on their chest, listening to them and seeing how they're doing. And we did have, obviously we went to telehealth, but it's definitely not as effective. And so I can't imagine what this will do to the statistics the next time around when we start looking at the global burden of disease and how we will adjudicate how much of these deaths were cardiovascular versus COVID-related deaths. So very, very difficult question to answer. Certainly a huge impact on the care of the patient with cardiovascular disease.
And do you still see that being a challenge, even with the availability of vaccines and getting patients to come into care?
No, I think what we saw was actually a surge of patients coming in with who were now much more sicker, uh, with their comorbid conditions not under control, and for them needing hospitalizations, and then us being nervous about, do we have enough beds for our cardiac patients versus if there's another surge? And those were our big issues. And during the pandemic, and when we had during the huge surges, especially that first surge, I absolutely recall being in the cath lab and basically seeing all of our procedures, elective procedures, putting on halt, but emergent procedures being open, and our hospital completely turned into labs for COVID positive patients, because some of those patients who had COVID presented with acute myocardial infarction and need to go into the cath lab. So it was really a very difficult situation. And of course, the thromboembolic complications, such as, stroke and blood clots everywhere, was also a really a difficult situation for everyone to handle.
I can only imagine. And are there certain things that your hospital or institution tried to do to potentially bring patients back in or make sure that they got the care they needed?
I mean, I'm really proud of our hospital system, and I think all of the New York City hospital systems working together hand in hand to make sure that not only that the COVID patients, and we basically all the health systems were using very similar procedures and algorithms, and sharing the data sharing, the sharing of the information was just so fantastic. Some are competing organizations, right? But still, during such a huge catastrophe that we were all seeing in New York City, especially, everyone came together, and we were working across different hospital systems, coming up with very good plans for patients with cardiovascular disease, those patients presenting in shock, and of course, whether it was due to COVID versus cardiovascular cause or a combination of the two, we put plans in place, procedures, algorithms, the way to address each and every one of those. And I think I was absolutely floored by the amount of camaraderie amongst everyone to come forth and treat these patients. I think we didn't miss a beat, honestly, and I don't think that and I'm proud of every hospital system that I saw in the New York City at that very difficult time.
That's wonderful. And speaking of data sharing, and what impact has COVID had in terms of advancing clinical research? If you'd like to speak to that, Dr.
I think the COVID pandemic is a strong reminder of how we can all come together and share data to come out. I mean, look what Pfizer has done, Operation Warp Speed. I mean, it's mind-blowing knowing what the usual pathways are and timelines are, but how we all came together as one to address these issues is quite incredible. And it really, and while you might get really depressed about everything that has happened, you also have to look at the silver lining of, I think, science won 100%, and we all came together in making sure that everything was being published. I'm an associate editor of JAMA Cardiology, and I can tell you that hundreds and hundreds of manuscripts were coming in, and we were all, the evaluation was absolutely right on, and to make sure that every single credible reports were being at the very least published as soon as possible. And of course, watching the data sharing has been really the best way forward. And of course, we saw how these randomized clinical trials came about with the National Institute of Health and everything that has been done. It's quite incredible.
Thank you. So in regards to the impact COVID has had on families, there's been a tremendous impact it's had on on mothers, on children, on the elderly, leading to isolation and increases in mental needs for mental health services. Dr. Vahabzadeh, could you please share some of your experiences and challenges you face with providing mental health services to children and families?
Thank you. Thank you so much. And I appreciate the introduction earlier. You know, as people, as families, as social units, we really depend on the people around us, our social connections, the activities that we kind of line up. And for a lot of families, having a degree of structure is important. And for a lot of kids or teenagers, having structure and a sense of predictability is important. And we know that the pandemic has really challenged a lot of these things on multiple levels. Things that, you know, people typically do. So this sense of social connectedness, you know, we asked everyone to socially distance. Perhaps it would have been better to say physically distance, but socially still stay connected. So we had a lot of people that essentially lost their support network or weren't able to kind of reorganize it in a way that helped them to deal with some of the ups and downs that this pandemic has presented. And this pandemic has really been a journey with lots of different stages, lots of conflicting or changing information that's come at all different levels. You talk to different people in the family, there's a lot of different different perspectives, different schools and different states and different political leaders and different healthcare organizations have put out different information at the same time and at different times. So it's been very confusing and very challenging. And for a lot of families with children, suddenly the living room or bedroom became the new classroom. So this sudden push towards this moving school into the home suddenly meant that families of 2 or 3 kids have suddenly got this environment where they have to kind of stay quiet and the child needs their space to do their studies. And often a lot of kids struggled with doing that. The schools struggled to adapt. So a lot of the core things that we did, that people used to do to try and keep their spirits up, you know, get on with day-to-day life, socializing, going to the gym, you know, going to school, having a social network, suddenly these things were disrupted. And it would have been reassuring for people to have light at the end of the tunnel, but we know that light came on and off or changed color, or we had to go down different tunnels throughout the whole experience. Again, very, very challenging. So in terms of mental health, I've seen a tremendous rise in anxiety and depression, and I serve across multiple states, overseeing multiple dozens of psychiatrists actually through a tele-psychiatry organization. And we're seeing a lot of ambivalent mood. What I would say to that is not necessarily someone being tearful and crying, but someone just saying that my mood is blah, like I just don't care. And we often see that mood in people who are actually much, much older, who have faced a great degree of social isolation. And, you know, imagine somebody that's in a nursing home that's very isolated. Sometimes they develop this kind of ambivalent or apathetic, unmotivated mood that, you know, we label as depression. But I've started seeing that as of about a year ago in a large number of young adults, mothers. And I think part of that is this ongoing social isolation that's taken away a lot of the motivation that people used to have to engage in social events, so much so that they just almost forgot about it. And you know, there's this thinking of, you know, well, what's the point, and when's this going to end, and even, you know, who am I without my, you know, being able to see my grandmother or mother or sister or brother, and not having any of the normal activities that define me. So yeah, challenging across the board.
That must have created an incredible challenge in terms of being able to meet the volume and the demand for patients who need your help. Can you share some of the innovative ways that you've come to try to meet some of those challenges during the COVID pandemic? Like I think at one point you had mentioned providing telehealth across states. You could give us some examples or other ways where you've tried to potentially providing more access for what's needed out there.
Yeah. So part of the work I do is also building out new digital educational technologies with a mental health component. So some of the efforts that we did were in relation to providing teacher education, scalable teacher education on mental health, but also with a social component, so teachers can actually interact in a kind of positive way with one another online, just allowing them to kind of de-stress, because we know teacher burnout is actually very high. It's not just kind of people or medical professionals, but every single service sector has had a high degree of uncertainty and burnout. We have a range of digital tools that we've also helped provide teachers, and these are in relation to documenting student progress, especially students that have a special educational need. So a lot of these students are on what are termed as 504 plans or IEPs, individualized education programs. And these are things that teachers have to kind of add into their normal studies to help students kind of progress. But there's a lot of burden on teachers to document and produce all this kind of paperwork and forms. And we know that the pandemic really not only challenged teachers, but really set back a lot of students, especially the students who benefited most from in-person hands-on support. So we built a series of digital tools that help to quantify and more rapidly allow teachers to do the documentation that they need so they can spend more hands-on time or virtual time with their students and get bogged down less. I mentioned about the telehealth program. Certainly a lot more, the mental health professionals have moved to tele. And despite this, feeling that this should help with accessibility, the demand has been such that, I think access is worse than ever, actually, just because whether someone's available digitally or not, or via tele, if they're simply completely full, it's just very difficult to get care. So on a daily basis, I have to reach out and ask for favors of various people that I've done favors for to get people seen, just because the systems are really pushed. And I was running a program for Kaiser a few months ago, and I mean, they were running into weeks and weeks and weeks of waiting time to see a therapist who would only see somebody once a month. So if you think for a child or a teen, once a month therapy is really far away from the standard that we want, which is at least weekly, right? At least. So a lot of challenges there too. So we need just a lot more many more clinicians to address the bottleneck.
Thank you for sharing that. And with that, can you speak a little bit to the experience of the mental health toll it's taken on frontline workers and healthcare workers?
The kind of mental health providers?
Yeah. Yes.
Yeah.
Sorry for you and your colleagues.
Yeah. Well, I think for everyone, I think for all the physicians, it's been a very challenging time. So it really caused a big push to go into telepsychiatry, telemedicine for a lot of the behavioral providers. I was until 3 months ago still doing in person. At the start of the pandemic, I used to get on almost empty planes actually to fly from Boston to California to do some of my work in the Bay and actually some of the correctional settings. And it was really difficult to travel. I mean, the plane was empty, but you get to the hotel and have to page somebody to come in to check you in, and half the lights are off. And this is, the better hotels in the Bay Area. So it was wearing. The logistics of travel more difficult. And once you start to have demand go up and people start to burn out, it's actually almost like a domino effect. So once people are sick or they've been asked to stay away, the burden kind of gets spread on other providers. So I know there was I think August last year, I picked up at least 300 hours on-site clinical work, plus 100 hours of call, because there was nobody else. And I mean, that was the last month I said I'm ever going to do on-site work, because it's just not feasible to pick up so much work. So,
is that because of people leaving the profession or?
No, that was actually because the demand was so high and people were already committed to so many different places, and they couldn't fill the positions. I think the relative number of people leaving is not that high, even though burnout is high, because they can almost kind of modulate how much they work because of the opportunity for telemedicine. But it means that roles like in-person work, inpatient work, or work where basically you're just, some of the roles I was doing, I had to just be adaptable to try and figure out how to fix things in a system that continuously, the rules are changing. The infectious disease guidelines are changing, who we can take on in certain units are almost changing day by day. And we're almost having to kind of make some of the things up to cope, or to empty out the ED, or to make sure the medical floors are functioning, and there's not just a lot of our mental health patients stuck waiting for beds. So and that kind of work is hard. There are not a lot of solutions to it, and that kind of wears people down, and it's a lot easier to do telemedicine and see outpatients rather than get stuck in kind of complicated healthcare settings.
Thank you.
Thank you.
So in the past few years, we've witnessed remarkable developments to protect against COVID. So I'd like to move the conversation towards talking about the vaccines. So we now have vaccines available for children and adults 5 and older. And recently with the surge, due to waning immunity and the emergence of Omicron, the CDC had recommended a booster shot to improve vaccine efficacy. Dr. Modjarrad, your team has been working on the pan-coronavirus vaccine. If you could please share with us more about what this vaccine development has been like and how it might be different than the vaccines currently available.
Sure. Thank you for that question, Sima. I think what's first most important to highlight is how the vaccine approach we're taking and those across the whole landscape are complementary with one another. And also to point out that the tools and the technology that led to the vaccines that are now in use today and that we're taking forward for the future are built upon years and decades of investments in the science of coronaviruses, of vaccinology, and some of the platform technologies like mRNA that we're using today. In the timeline that you presented, which is a really powerful presentation, in between the 2 dates of January 7th and January 13th was another really important date, which was January 10th. That's when the full genome sequence of SARS-CoV-2 was published. And that also marks in many ways the start of the clock for the vaccine development programs. But there was another clock that had started much earlier. And I think much of the public is not aware and should be, in order to boost confidence in the safety and the efficacy of these vaccines, because people think that this all happened within a year, and in many ways it did. And Operation Warp Speed was an amazing endeavor to be able to move at that pace. But I can talk about this from a personal perspective as well, because I had been at the NIH at the beginning of the initiation of the coronavirus vaccine program at the Vaccine Research Center. And I think there was a lot of prescient investments to focus on the development of vaccines against coronaviruses all the way back in 2012. And it was based on an understanding that we had SARS-CoV-1, we just knew it as SARS-CoV back then, emerge in 2002, and then 10 years later, MERS coronavirus in 2012. So there was a sense amongst certain individuals that that it was likely that another highly pathogenic coronavirus might emerge. And thank God that those investments were made early on, because it was based upon the science that was done for years before that we got to the point where we could make these vaccines very quickly. And so what we're trying to do with the vaccine approach that we're taking is establish another clock and start in advance of the next pandemic. Because we knew that we had to start before the pandemics occur in order to have the right science and the right technology in place when the pandemics actually emerge. And so what the approach that we're taking and that we started taking from January 10th, 2020 was one that was complementary with the other vaccines. One that was based on a platform with which we had worked with in the context of universal influenza programs, universal influenza vaccines at the NIH. And the concept is pretty simple. It's the idea that you can present the most important part of a virus. In the case of coronaviruses, it's the spike protein that mediates attachment to your lung cells, and take the spike or parts of the spike from different coronaviruses and decorate a particle with all those different spikes, so that what you present to the immune system now is something that you can elicit responses to very broadly, and that will protect you from multiple coronaviruses at the same time. And what we're trying to do here also is develop a response that's broad enough that potentially would then be effective against coronaviruses we haven't even seen yet. Ones that might emerge in the future, jump from animal populations into humans. And that, I think, is something that will also take a lot of long-term investment. I think we have to still develop some of the technology. We still have to discover some of the science to be able to do that. But because of the track record that had been seen before with doing those sorts of taking the long-term approach, I think it's a very doable endeavor.
Wonderful, thank you. Is there any prospect of knowing like how the timeline for this type of vaccine and what that would mean in terms of, I guess, for the population, since it could potentially protect against future variants, would there be a need for any type of boostering?
Yeah, I think it's also important to point out that we're not saying that there may be no need for the current vaccines as they are in the future. I think the time will tell and the science will guide us. In terms of the timelines for vaccines like ours, well, we're at very early stages. We're about to present the results of our phase 1 clinical trial. So there's a long way to go from phase 1 to get to something to licensure. We also have to, as you understand, being at a place like Pfizer, you have to sort of set the metrics as to how do you approve a vaccine against viruses that we don't even know about yet. So some of the regulatory science has to be developed as well. Dr. Fauci had presented a few weeks back in a White House press briefing the efforts underway for universal coronavirus vaccines, in which our vaccine he highlighted as one of those potential approaches. And what he stressed was, this is not something that's coming tomorrow. This is something that, again, will be a goal that we're targeting years from now, several years from now, just in the way that we developed the science 10 years before to get to the vaccines that we could license within a year. So just like we had Operation Warp Speed, we had this this massive public-private partnership take place. I think we need to do that same sort of approach, kind of like a Manhattan Project, to develop these anticipatory vaccines that will be in place before the pandemics occur, so that we're not in a reactive posture, and we're not even in a prepared posture, but that we're in a preemptive posture, that we can take the first strike with vaccines that are already in place before those viruses emerge.
Could you speak a little bit more about the public-private partnership that took place? And is that new with the COVID-19 pandemic, or is that something that was in place before?
Yeah, it's a great question. And again, it's one of these things that evolves. Nothing ever emerges de novo suddenly. It's always built on a progression of iterations that sort of work themselves out in terms of the vaccine science, in terms of the vaccine platforms. Well, also the form of the public-private partnerships have been evolving with each epidemic, which each global health emergency in the context of the Ebola outbreak in West Africa in 2014 to 16. And then more recently, the Zika outbreak in the Western Hemisphere in 2016. What formed in the federal government as a response to that was something called the Zika Leadership Group that I was fortunate to be a part of and that Dr. Fauci chaired. And that formed the basis in many ways in terms of the structure, in terms of the hierarchy, in terms of the different working groups coming together and interfacing with industry as a model and an initial iteration of what would eventually become Operation Warp Speed. And I'm sure that we'll look back in retrospect and look at how Operation Warp Speed functioned, what worked and what didn't work. You know, now it's called the Countermeasures Acceleration Group, and then make it better for the next iteration, for the next public health emergency. But I think what it did show was definitely the power of public-private partnerships, that you really need both sectors. You need industry, and you need government, and you need academia, and all the different partners in between, kind of to sort of entwine and create this fabric that will ensure rapid and successful development of vaccines, diagnostics, and therapeutics.
Thank you. I think it's been a remarkable display of that with this pandemic. So thank you very much for that. So now, as we're going into our third year of the pandemic, and as we had mentioned earlier with the Omicron, the variant and the cases steadily declining, many of the states across the country have been getting us ready for the next phase. Some of the measures that we had in place to keep our community safe, like masking and so forth, are becoming less restrictive now. And so states across the country are allowing persons to walk into businesses and schools without masks. So Dr. Pooran, what is your perspective on this next stage? And as we try to move towards normalcy, what are things that we can do to potentially do it safely?
First answer that comes to mind is scary. I'm not sure what normal really means anymore. I think this far into the pandemic, the entire fabric of kind of society has changed somewhat. I think inflation, what's happening in Ukraine, the global order, the things that I think we became comfortable with for the last half century have all kind of been undermined. And I think the pandemic played a huge part in that. I think neighbors started looking at neighbors differently because they weren't willing to mask, or they were willing to mask, or kind of what they're, and I think people are going to carry some of those, feelings with them, even moving forward. I think the issue with the children was brought up. I certainly have young kids, and their worldview is very different. It's interesting because when I started training, we had entire wards filled with HIV patients, and we had very little that we could do for them other than just kind of support them in the process of dying. And over the early part of my career, we got the antiretrovirals and HIV changed. But a lot of our younger doctors were completely surprised by entire units filled with one disease. They just weren't used to that phenomenon. And so I think it's been an educational awakening. I certainly think there's a lot of things that we're going to learn about inflammatory process, and just how viruses affect the human immune system. I think there's going to be a lot of growth on a positive side in terms of medical technology, medical sciences over the next 20, 30 years, which is going to only improve the way we deal with hypertension and heart disease and all the things that COVID seemed to really particularly key in on for reasons we don't quite know yet, right? So I think it's going to be interesting how the next years evolve. I often tell my fellow physicians and nurses that this a lot reminds me of Vietnam in terms of the Vietnam vets who came back. You had a society that was divided about how things should be going and shouldn't be going. There was a lot of emotions. I think everyone assumed that the administration that was in charge was doing a pretty bad job, irrespective of what political party they were coming from. There wasn't much trust in government. And the people who were the professionals doing it were being blamed for it, even though it was just their job, right? So aside from the burnout, I think there was, especially towards the end, a lot of animosity expressed towards the healthcare professionals who were just doing their day-to-day job. We'd have people come into the ER from something completely unrelated to COVID, and we'd have to put them on life support and put them on the ventilator, and the family would just be beside themselves because they would think that we're giving him COVID by putting him on the ventilator. So a lot of these things just have so much harm and just secondary effects that you don't quite understand until you're in it. So I don't know. I don't know what new normal is going to be. It's going to be different. I just hope that we come out of this a smarter, more well-rounded society that cares for each other. I think, but that being said, the numbers are down. I do think we have to start approaching life and look at our social bearings and say, okay, it's time to, be reasonable about the mask mandates, and can we take the masks off, and when is it appropriate to do so? Can we be comfortable being close to one another again in social gatherings? Those are important things. And so, these are questions I ask myself every day. And I have a lot of friends and a lot of our associates who look at me and go, well, you're running the COVID ICU, so you know what's going on. And I go, well, this is what I'm doing for myself. I can't tell you if it's right for you or if it's not right for you, but it's right for me and my family. But at the end of the day, I think we are moving towards kind of a healthier balance on this. I do think that that's ultimately where we're going to end up. And the last thing I'll add to this is that there is a degree of personal comfort. And I think some people are going to come out of this wanting to wear the mask all the time. I love the fact that I wasn't getting sick every week from 3 kids being in elementary school. I don't know next year. Will I encourage my kids to continue wearing masks because it's just going to keep the common cold away and, keep them in school and keep everyone healthy? I don't know. I don't know what that's going to look like, but I think these are all conversations that I look forward to us having, hopefully in an intelligent manner.
Thank you for that. That's true. It'll take some time to really understand what the new normal will look like for everyone. So some experts have said that, speaking of transitioning to somewhat of a possible new normal and what that new normal looks like, there's also a lot of discussion about, will this pandemic evolve into becoming an endemic disease and what that really means? So what I would, and how does a disease like this go from being pandemic to endemic, and how is that defined? I was wondering, Dr. Modjarrad, could you potentially speak to that? Like, what does that really mean that a virus has become endemic, and what would that look like for us?
Yeah, it's an important question, I think, that everybody is wondering, if not exactly in those terms. Viruses have evolved to mutate, and viruses mutate to evolve. This virus is no different. It's an RNA virus. RNA viruses have a tendency to mutate pretty often, and the more they circulate, the more opportunities they have to mutate. What we tend to see with respiratory viruses is that they mutate to become more transmissible in many ways. It makes sense. Those that are more transmissible have more opportunities to then reproduce more. And if they can keep their hosts alive, so if the disease is less severe, they again have more opportunities to reproduce. And so what you're seeing, I think, paradoxically with Omicron, despite the much higher numbers, as Milad had outlined, is that you still had lots and lots of mortality and morbidity, but proportionally less. And this, in many ways, spelled, I think, the beginning of the end of the pandemic. That this virus was, you could no longer sit this one out. You were either going to be vaccinated or you were going to be infected. One way or another, you were going to be primed with some level of immunity. And with that kind of herd immunity starting to take effect, a term that the general public has become a lot more familiar with in the past 2 years, as well as the transmissibility of this virus approaching some of the most contagious viruses we know of, like measles and smallpox, that we're getting to a point in the global population where the virus is not going to have any new people to infect. So then the question becomes, can you get reinfected? What we've seen is reinfections tend to be a lot less severe, irrespective of the type of virus we're talking about. And then the question is also, how long does prior infection and prior vaccination provide some sort of level of immunity? There are very specific epidemiologic definitions of what is endemic versus pandemic, especially in the context of other respiratory viruses and the flu literature. But I think more importantly is kind of the social definitions of what is endemic and pandemic. Is it now getting to a point, as has been alluded to by our other speakers, of having some sort of new normal where we can re-engage in activities that we weren't able to before? Yes, I think we're getting to that point now. And how that evolves over time, you know, I'm not sort of, we don't have really a good crystal ball to look into. It's pretty cloudy to really understand societally how that works. But from a virological perspective, I think we're really getting to that point now where we're seeing this public health phenomenon transition from a pandemic to an endemic situation.
Thank you so much for that, Modjarrad. Thank you so very much for all of our panelists. I did want to give our audience an opportunity to ask questions, as we don't have a limited time left. So I will. So one of the questions are, if we could, so the question is, could we please elaborate further on the path forward regarding the need for a booster COVID vaccine following the third dose? Is there going to be a new dose needed now that we are in the endemic era? Would you like to answer the question?
I'll take a first stab at it. Sure. So there's been sort of a natural experiment done in places like Israel, where they had a fourth dose. And what they saw was that there wasn't much added value, added benefit in terms of clinical outcomes with a fourth dose compared to the third dose. What you see immunologically is between the second and third dose, there is a real expansion of the B cell memory response that gives you a lot more in terms of the antibody arsenal against not just Omicron, but potentially other viruses as well. So you're sort of getting a boost in the potency of your immune response, but you're also getting a boost in the breadth of your immune response. How that translates into the durability of your response, that obviously, literally, time will tell as we interrogate the immune responses and the outcomes of individuals who have been boosted that second time, got the third dose. So at the moment, we're sort of following the data very closely and making policy recommendations based on the data that are coming in, and seeing that a third dose really is critical to boosting the efficacy of these vaccines, but that as of yet, we don't see the value of having a fourth dose with a homologous, the same vaccine. Now, going forward, are we going to need if we do need boosters, will we need a booster with the same exact vaccine that we received initially, or will we need a sort of a tweaked vaccine, something that I was talking about with the universal approach, something that will sort of give you a broader response to things that are coming in the future. It's important to remember, people will ask a lot of times, well, why didn't we just start out with 3 doses in the beginning? Why did you guys have to sort of come in at this? Principles of vaccinology have always taught us that, and in a lot of the immunization series that are approved for kids, that you often have 3 doses, like the Tdap or DTaP, you have, or hepatitis B, or even HPV vaccines. And so why didn't we start out with 3 doses? Well, it was a race against time. This was a pandemic vaccine regimen. We wanted to compress the time. Oftentimes we don't even do 0 and 1 month. We space out to 0 and 2 months, or even 0 and 3 weeks, like the Pfizer regimen. So we wanted to get as many people vaccinated and provide them some level of baseline immunity to begin with, before we started talking about third vaccinations. But I think from primary principles of vaccine science, we knew that in order to get a much broader response and potentially a durable response, we were going to need that 3rd dose. Beyond that, again, time will tell.
Thank you for that. There is another vaccine question, and it's related to children. Now that we know that
To be able to take that one.
And well, the question is for children 5 to 12. Now that we know that it's not as efficacious, what is the outlook for that? And I think what we really don't know yet, as far as what the next steps are, and I think that's currently being evaluated. Sorry, I can't speak more to that, but it is being evaluated what the next step is for that, and if there will be anything else needed for that population. And then let me see. I think we have. And I think that's all we have for questions, actually. And we've hit our time. Thank you so much, everyone. This was a really wonderful discussion. Layla, I don't know if you have anything else you'd like to add right now, but I really appreciate everyone's time. It was very engaging and wonderful discussion, so thank you very much.
Yeah, I do. Thank you. I know we're out of time, and I just want to also add my thank you to our panelists and our wonderful moderator again for your time and generosity in sharing your insights with us, and for the important work that you do to keep us safe and healthy. I know that I came out of this discussion more informed, empowered, and inspired by all of you. Thank you. I also want to wish everyone a happy and healthy Nowruz. I know that we're all hopeful that spring and the dawn of a new year will bring with it an opportunity for renewed optimism and hope. Thank you for everyone for joining us tonight, and please stay in touch. Good night.